Hey y'all, welcome to
Chief
Chief Complaint
Tacky,
and Caffeinated. I'm Jess.
and I'm Britt.
We're two nurse practitioners, moms, wives, and longtime friends who met in nursing school, and somehow we've managed to juggle evolving healthcare, careers, and our home lives.
This is where we talk about the things that don't fit into a 15-minute visit: healthcare, beauty, motherhood, marriage, business, burnout, and whatever else life throws at us.
Two in peace
Real life.
and fully caffeinated.
Hey y'all, welcome back. We're going to do episode 2, Pet Peeves.
Yep.
Just things that kind of bother us in our profession, whether it's things that we see other providers do or
Not
do, things that maybe the patient could work on their end to help us to help them.
Yeah.
And so we'll just get right into it.
Yep. Urgent care versus ER versus when you need to see your primary, as far as where should you go when you're sick and what warrants, going to the urgent care, ER, or waiting for your primary care. And we've worked in all kinds of different settings where we've seen patients come into all those settings when I think if we could inform you on which type of things are more urgent versus emergent and then things that could wait, then I think it would decrease the clutter that we see, one in the ER, one in the urgent care. So let's see, if you're having chest pain, urgent care is not the place to go. We can work you up, but if it is truly a heart attack, you are going to the emergency room.
Mm-hmm.
Another one is weakness, numbness, blurred vision, inability to walk or talk. Any of that, we can't work you up for a stroke in the urgent care. We only have x-ray at most facilities, and so you're going to be going to the emergency room. Fractures we can do in the urgent care. We can set them. We can put a splint. We can get a referral somewhere. Sore throats, colds, STD testing, urinary tract infections, things like that. Sometimes we do workers' comp things or just things like that are more urgent care. And then primary care, if you've had the sniffles for 2 days, you probably shouldn't go to the urgent care. I mean, you're going to sit there for hours amongst people that probably really are sick, and you haven't tried anything over the counter. Try some things. If it's not emergent or not an urgent need, meaning it's life-threatening, you could lose your life if you didn't do something about it, it most likely can wait for your primary care. Don't use the urgent care or the ER as your primary care. Establish with a provider so that they know your medical history. You get better rounded care, continuum of care, rather than going to get your blood pressure medicine filled at one of those places. So I think it's just educating patients and letting them know what is the proper environment depending on what their medical need is.
Yes.
Would decrease the clutter. And it's hard, to decide, where to go. But if it's something you can live through the weekend, you can live a few days, it's not life-threatening, you most likely can wait for your primary care.
Yes. And for me, it's any head traumas with taking a blood thinner, period. You are probably fine. You could be fine. However, that's a life-threatening miss, and we're not going to be able to do the CT scan or anything to rule that out. So that's a
Time's ticking.
ER for me every time, regardless. Better safe than sorry scenario.
Yeah.
I don't so much mind cold and flu in the urgent care if we're not busy.
No.
Yeah, cold and flu. I feel like keeping them out of primary care helps cut down on the spread a little bit too. I mean,
it's just if it started that morning or last night.
Like
my throat's a little itchy and my nose is running. Like, have you tried anything over the counter before you go and have to sit and wait for long periods of time to get in to see urgent care? Right. And then you come back and we see you and we tell you to go try XYZ over the counter, or have you done this? Conservative things.
Yeah, save yourself some time.
Yeah, I think it would save headache and time if you knew, some things you could try.
Yes, and it helps narrow down a diagnosis too. Because if you haven't taken these cold and flu medications, then we can't really narrow things down.
Right.
Like if we don't have a good idea of what makes it better, what makes it worse, then we can't really help narrow down a diagnosis.
Yep. And everything doesn't want an antibiotic every time you're sick. Our bodies should fight illnesses. We don't need to create these, what we call super bugs, because these places become so backed up. Physicians and practitioners will just hand out antibiotics like
Take
crazy.
it and go.
Yeah. And then one day when you really do need that antibiotic, you're resistant because you've gone to the urgent care, the ER, and they've given you amoxicillin every time. And then you're really dealing with a life-threatening illness and you cannot use that drug. So,
yeah, that could probably be another pet peeve for mine too. They're like, well, I get this every 6 weeks and they give me an antibiotic and it's better and I get a steroid shot and I'm good to go. I'm like, first off, if you're getting it every 6 weeks, we need to evaluate that in itself. But secondly, we've got to be judicial with antibiotic prescriptions, and it's not for our benefit. You know, like it's really for your benefit.
Stop being just lazy medicine, and being more prudent.
Yes.
Yeah.
I think one of my pet peeves would be not trying least invasive measures first. So that can kind of pigtail off what we were talking about antibiotics and stuff. Like our bodies are made to fight infections or to fight off some illnesses, and I appreciate least invasive measures first, right? So trying gargling with warm salt water, trying, nasal saline rinses, trying over-the-counter medicines if appropriate, and then if not noticing any improvement, then let's look at the next step. But I don't feel good about day one symptoms, negative flu, negative COVID, negative strep, just being like, okay, well, you've had symptoms less than 24 hours. Let's go straight to steroids and antibiotics. No, every medication has a side effect. Yeah. And so
the ones of us that do it correctly, the providers that aren't doing it and they're just handing stuff out so that they can get through to the next patient, it makes it a lot harder for us that actually try to do it appropriately and educate, because then the patients are resistant. Mad.
And they're upset with us. They think that we just
holding out
just holding out on the good stuff.
Yep. I agree.
And then I guess like kind of same scenario of trying like least invasive measures first is like trying lifestyle modifications and diet and exercise depending on the diagnoses or the disease process.
Yeah.
Just trying least invasive measures first. Like, let's try to work on our overall health before we start with medications.
Yeah. Yeah. I agree. I think we could fix a lot of things that way. On top of that too is just waiting. If you've got sinus stuff, wait until it's like 5, 7, 10 days. Then we start worrying about a bacterial infection and it's gone too far and you've tried the things, then that might warrant an antibiotic. Or you've been coughing and now it's productive with a fever and it's been over a week. Yes, then you really probably should go in and see someone before it develops into a pneumonia or is one. So we're not saying not to go. It's just knowing when to go and trying things before you go. It'll save time for you and heartache for you when we tell you, this is just a virus.
Yeah. Or I think that, I guess the caveat to that is like, if they are somebody that would want to take Tamiflu and they have to come in within the 24 to 48 hours of symptoms,
that's understandable.
In order to start the Tamiflu. But again, if you're one that's more conservative, like myself, I'm probably not going to take the Tamiflu, like Brittany said, wait, try your home remedies, over the counter, cold medicines to help manage the symptoms as needed. Stay hydrated, stay active as possible, just to try to prevent these secondary complications.
Yeah. I feel like, I grew up with a nurse, and by golly, you were not going to the ER. You were not going to the doctor unless it was something she couldn't fix.
Right.
So I feel like I've kind of taken that on too. Like if my kid has 102, 103 fever, I'm going to deal with that fever until it's just uncontrollable. I have parents come in and it's probably their second or third child. It's not their first child. And they just started with a fever an hour ago. I'm like, did you try anything? Would you like for us to give them some Motrin?
Yeah.
And they waited hours in the lobby, and it's just like, there's things you can do. It's just using your resources, using your brain, using things that you can try before you actually have to go consume your time.
And this is speaking more on like upper respiratory stuff. Like certainly if they've been having like abdominal pain or any other red flags like that, and then start to develop a high fever, then that would be a different story. But this is just more for cold symptoms in particular.
Yeah.
Something that's more prevalent.
Yeah.
So another pet peeve of mine is when we as providers are so busy, like trying to get in and out, trying to meet that day's quota of number of patients seen, that we don't take the time to educate our patients. And like in particular, it's starting a new medication and not educating them on potential side effects. So probably the biggest scenario that I've seen is with like amlodipine, right? So you have a patient with high blood pressure, they're started on amlodipine. Here you go. A lot of providers will tell the patient, keep a home BP log, notify us if their blood pressure is staying high, and we'll adjust the dose, what have you. But then we forget to tell them, like, by the way, like if you start to have any ankle edema, don't be too alarmed. Just let us know. We'll reevaluate, because pedal edema is a very common side effect with specifically amlodipine. And so the scenario that seems to happen is we start a patient on amlodipine. They go home, they're compliant, they're taking their amlodipine, they're keeping their home BP log, their blood pressures are staying stable, like they're not high, they're improving, but they have ankle edema, but their PCP doesn't have any openings for the next month. So the patient's concerned. So they go to an urgent care and they're, oh yes, I have high blood pressure. And then they see ankle edema and they're like, okay, well, here's your diuretic. And it just starts this cascade of polypharmacy. Well, guess what? They didn't tell you that diuretic may cause some electrolyte imbalances. So now you're having these other symptoms from probably low potassium level. And so then you go somewhere else, they check your labs, your potassium's low. Well, now here's a potassium. And it's just this cascade of events that probably
could have been prevented.
Like, again, this goes back to also least invasive measures first, like let's change the amlodipine. If we can educate our patient that this might be a potential side effect, then they can advocate for themselves if they have to go to the urgent care. Like, hey, I did just start this. My primary care doctor told me it could cause some ankle swelling. I'm having it and it's really uncomfortable. I can't live with it like this. Like, I want to make a change. Then, working in the urgent care, you're always kind of leery of overruling or changing meds that the primary care doctor or specialist have decided on. But neither here nor there. Like, we could redirect the patient where they needed to go from there. But the main thing is having them advocate for themselves and maybe changing the amlodipine. Like, I guess the scenario, you come to me in the urgent care, I have all this information, everything else looks good, your blood pressure looks good, you're not having any other symptoms, no shortness of breath with exertion, things like that. Then I could say, okay, I understand that you've just been started on this amlodipine. When can you talk to your primary care provider? Can you leave a message with the nurse? A lot of times in primary care, if you leave a message with the nurse, then they can speak to the provider and then they can just make that change without you even having to have another visit. So I guess
a lot of meds are like that too, that have side effects, and because the patient was not educated. Another one that I have seen is Jardiance.
Oh, yes.
Females come in, or males, and they've been treated for several yeast infections or several UTIs in the last couple of months. And as an urgent care provider, I then have to run down, yes, I could just give them something for a yeast infection and be done with it. But then I start looking at the meds, because one, I'm a curious being, and I'm like, what are they taking? And when did you start this? And when did you start this? Oh, I've just been on the Jardiance a few months. I was like, okay, well, when did the symptoms start? Well, I've had like 3 yeast infections since then. And then I have to do the education when I've got a lot of, 30-something people waiting in the lobby saying that is a very common side effect with that class of medication. And the patient's like, well, why didn't my primary care? I don't know, but you should go see them and see if you can get that changed so that this isn't a recurrent issue and you're not having to visit the urgent care every other weekend.
Right.
And so had she known that, it could have saved her so much time and heartache.
Yeah. And the reason being is the way that medication works is it gets rid of your sugars through your urinary tract, right? And so yeast love sugar. They love warm, dark, wet places. So it's a perfect breeding ground. So so you're right, like that. Another one too is clonidine. I have so many patients come in that are taking clonidine, whether it's for insomnia, off-label use insomnia, or for hypertension. and all of a sudden, like, their blood pressures are like skyrocketing, and nobody's educated them on rebound hypertension, you know, and so just making the patient aware can cut down on a lot of unnecessary expenditures, visits, and polypharmacy for the patient.
That is a pet peeve for medical professionals. Like, that is something we feel like we could do better at as medical professionals.
Absolutely.
That's our job.
That's nothing on you. You know, of course,
you would
ask questions, you know, don't ever feel ashamed or embarrassed or bashful to ask questions to the provider, or if you think of questions after, you know, a lot of patients have white coat syndrome, kind of shut down when the doctor's in talking. If you think of questions later, you know, we're blessed to have nurses to kind of help answer some of these questions for us and for you after the fact. So just don't ever be afraid to ask.
Right.
But for us, for sure, we should be more attentive to making sure that we're educating our patients.
Yes.
Anytime we start a new medication,
that is our
what
job.
the black box warnings for these medications are, and what common side effects are, and what to do if you're experiencing common side effects that are not tolerable for you.
Yeah, I agree. Not having a med list when you go to your provider's office. This is for patients. When you go into your provider's office, especially if it's the first time you're seeing this primary care provider and you know none of your medicines, you didn't bring them with you, you don't have a list. So then I've got to come out of the room and tell the nurse, call this pharmacy and find out what all medicines this patient's taking. You know, and it could have sped things up had you taken a list with you. And it's just a list you can print and put in your wallet or your purse that you just always have readily available. If you ever have to go to the ER from a car wreck or something, at least you've got the list, because then we don't have to go down this rabbit hole of what are they taking, because I need to give them this, but I don't know if they're taking this. So having a list would make it so much easier for your provider and your nurse that you see when you go into your appointment. It would really help.
Right. And even if it's not a typed up pretty list for the type A personality people, for the more type Bs, you know, you can write it down or just take a picture of each pill bottle morning before.
Throw in a Walmart sack.
Sometimes it's gross. So when you get some pill bottles where I don't know if they've licked the side of them or what, but there's stuff stuck all to them, you know. You can do that, certainly. But
just bring in a list, knowing what they are.
Just knowing what they are at minimal. Bringing a list, taking a picture, whatever, so that we can make sure that we're not forgetting any medications. And then it goes back to that same rationale that we were just talking about. You know, you come in with these symptoms, and these symptoms could be related to one of your medications. And if we don't know that, it makes it harder to catch. And it may send us on like a wild goose chase, labs, unnecessary diagnostics ordered that we could have maybe saved you money on that had we just known what your medications were. This is going to sound harsh, but I can't, for lack of a better way of presenting it, is patients being bullied by their providers. That is a pet peeve of mine, right?
Yeah.
I look at it like it's kind of like a customer service ordeal to an extent. You know, like the patient is choosing us. They're paying for this. They're paying for insurance, which is astronomical.
Yeah.
They're paying for the visits. I want them to get the most for their money, you know, so I want them to be heard, and I want it to be a realistic plan for them within reason. Yeah. Right? Like, if your blood pressure is stroke level high and you've already tried conservative measures for 3 months or what have you, we're going to have to talk about starting something for your blood pressure to get it controlled so you don't have a stroke. Right. Or so you don't have kidney damage or brain damage, vision damage from uncontrolled high blood pressure. But if you come to me and you're like, yes, my A1C, I'm pre-diabetic, but I don't want to start anything right now. Perfect. Let's try least invasive measures first. Right. Let's try diet and exercise. You know, let's go over some realistic goals and tips. But if you come to me, you're pre-diabetic and you're sitting there and you tell me, listen, diet and exercise is not an option for me. I'm telling you right now, I'm not going to be compliant with it. I'd prefer to just have medication. Right. Okay, let's start medication. Yeah. You know what I mean? Like, I want to do whatever is best for the patient within like are appropriate standards of practice and following specific guidelines that we need to follow. But,
right. Not you have to take this.
Let's not just jump to strong medications right off the bat if that's not what the patient wants.
Yeah. Because they're less likely to do it. You know, if you're telling you have to take this, and if you're not going to follow what I say, you're going to have to find another provider. Like, there's a lot of providers like that. They're so rigid, and it's like your patient's not going to do what you want them to do if you don't meet them halfway. Like, you need to know what they're willing to do, and I'm okay with that.
Yeah.
Like, if you don't want to do a colonoscopy, you want to poop in the box and do the Cologuard, okay, let's do it. But let me tell you why I think that that's a waste of time. Let me tell you why we will most likely end up doing a colonoscopy anyways. So, and I think nurse practitioners do a better job of that, of telling their patients, this is why we're trying to prevent your blood pressure from staying like that for the next couple of months. This is why you should just get the colonoscopy, because they can remove the cancerous polyps then. You don't have to wait and delay, you know, a cancer diagnosis. So I feel like we as nurse practitioners, and this is just because I'm biased, but one, because I've seen it, we spend more time making sure our patients know why we're doing what we're doing. We're not just doing it because that's what we were taught and that's what the guidelines say and the standard of care is. No, this is why. This is why.
Yeah. And I think that we listen to, like, what are your reservations? Like, what is your hesitation of getting this colonoscopy done? Let's talk through, you know, what's a rational fear and what's maybe an irrational fear and how we can meet in the middle. Or, you know, like, again, goes back to education. Like you're saying, like, let's have this discussion and figure out what is a realistic plan for you to do. Yeah.
Instead of forcing them. I too use, which, I mean, somebody may say it's not okay, but scare tactic. And it's not scare tactic I made up. It is experiences I have seen as a bedside nurse that could have been avoided had that patient listened to their provider and taken their diabetes medication and taken their high blood pressure medication. Then we wouldn't be sitting here on life support having dialysis done every day. Like, had that patient been educated or been told, this is where you're headed if we don't do X, Y, Z, maybe things would have been different, you know? So I do share those stories of, you know, these patients that I took care of that didn't have legs because they didn't take care of their diabetes, you know? Just taking care of yourself, empowering you to take control of your healthcare. I mean, it's your life and it's your body. We can guide you, but we can't make you. And so when it's too late, it's too late. You know, then yes, we're going to care for you, but they could have been prevented if you did the things we tried to tell you to do before.
And I think developing that level of respect for one another, the patient and the provider, plays a different role, because I can't think of any scenarios off the top of my head. There may have been some, but I can't think of any in which I educated the patient of, like, listen, it's your body, your life, your choice. These are my recommendations, and here's why. You know, here's warning signs, red flags to look for. You know, do what you will. If you decide later that you want to do this, just let me know, and I'm happy to put in the orders for you. There's not been any scenarios where after we have that discussion where they're like, okay, you're an idiot, like, I still don't want to do it. Like, F you. Like, nobody ever does that. They usually end up doing what's recommended.
They know you care. If you've gone that far to tell them that, they're like, she might actually care about them.
Yes, as opposed to, you need to get this done or else, and then walking out of the room. You know, like, that kind of creates a level of distrust, maybe.
Yeah.
You know,
I'm just a number. You know, I'm not an actual person.
Right.
That leads into screenings.
Yes.
Screenings, how important they are. A lot of patients think they're a waste of time, but it can be a choice between life and death. You know, because a lot of things you catch early, I mean, we can prevent, you know, the outcome. But if you're just being resistant because of what you've read online, mammograms is one that comes to mind, because I do a lot of hormone therapy. My women that are of age, they have to have their mammogram and their pap, especially if they have their women organs, and they must be clear to continue on hormone therapy. I will not continue to prescribe it unless you are in a safe zone. Also, if you're a patient or a young female patient and your grandma had breast cancer and your mom had breast cancer and you haven't had any genetic testing, let's do some genetic testing. You know, you want to do hormone therapy, but let's see if you're even a carrier. Let's see what your risks are versus the benefit, you know, of taking the hormone therapy. Let's look at the entire picture. One patient told me she would not do a mammogram because it causes cancer because of the amount of radiation that she's exposed to. And she just thinks it's a way for insurance to get our money.
Yeah.
I was just like, no, we're not doing this for fun. And so then I came up with data for her about radiation. Like, you're exposed to more radiation walking on Earth for 7 days, just doing your normal thing, than you are within the couple minutes that you are having that mammogram done. Or going up in an airplane and flying from A to B, you're more exposed to more radiation doing that than getting a mammogram that could save your life. And so I have talked a few people into doing their mammogram when I tell them that, and it's like I had to go do my own research to say, how am I going to get them to understand that it does not cause cancer? So then I bring the scientific evidence, and then, okay, I'll do it.
Yeah.
Okay, great. I'm happy. But if they didn't want to, and I was looking at other options, like an MRI is the next option, but your insurance is not going to pay for an MRI for a screening for breast cancer when you could have done the mammogram. So,
right. Well, we can get into insurance in a minute because insurance still, even with mammograms,
the bane of my existence.
Yes. But I do want to go off of what you're saying with the screenings. At minimal, I do feel like if you're having symptoms, something doesn't feel right, something's off. At minimal, get your basic routine labs done, right? Me, myself, a couple years ago, I was having these symptoms, and then me being a provider had an excuse for everything, right? Like I knew what it was. It wasn't a big deal. Yeah. But I mean, my hair was falling out. I couldn't lose weight regardless of like extreme calorie restrictions. Like I was only eating chicken for lunch basically, and having my iced coffee. But anyways, I would be so cold that in the middle of summertime in East Texas, I would go sit in my car with it not running to like warm up. And you know how hot that gets. Yeah. So I was like severely cold. Let's see. Oh, with minimal exertion, my heart rate was shooting up to 180. Like I've always been active, I have periods where I don't work out as much, but I enjoy working out, and I'm strong, never had issues lifting weights, but I would bend down to pick up the kettlebell, and just that exertion, my heart rate would shoot up to 180. I was having this weird ringing in my ear, which the tinnitus, it was tinnitus, but it was bizarre because my husband and my kids could hear it, which is not typical with tinnitus. So I don't even know if I can truly call it tinnitus, but it was like a whooshing sound in my ear all the time. Migraines that I couldn't really so finally I'm like, fine, it's probably my thyroid, and I was eating ice like no other. So I was like, it's probably my thyroid, stress or thyroid. I'll go ahead and get labs while I'm here at work. So the doctor I was working with, she pulled labs for me, and my hemoglobin was 6. I had a critical hemoglobin level, walking around, working, trying to be mom, coach.
All the things. Hospitalized with
and looking back at pictures, I was like, oh my God, I thought I looked so pretty. I looked so sick. Like I could tell in the pictures, like Botox and filler weren't fixing those bags and stuff that I was having. Okay. So,
and a normal hemoglobin is
like 12.
Yeah. So you see where she was.
Yes.
Half of what her body needed.
Half. And 12 is conservative. I think it's like 12 to 14 for women and like 14 to 18 for men, something like that. So anyways, I had to go get a blood transfusion. My iron level was like not registerable. It was like 0 when they did my ferritin. And so I did have a blood transfusion. I had an iron infusion. And then since then, I've been making sure that I implement iron in my diet. And then on days where I'm like, oh, you know what? I really didn't have much iron today. I'll take an iron supplement.
Yeah.
But my energy level, I never eat ice anymore. Never, which is weird. At normal temperatures. I got up to running 6 miles. Never in my life have I ever been a runner.
Yeah.
And I was up to running 6 miles after I was feeling better.
Yeah.
So, I mean, anyways, I could go on. All that to say, like, it could be something, a more simple fix. Just don't ignore your symptoms.
Yeah.
At minimal, get routine labs and see what your body's trying to tell you.
Yeah, absolutely. You knew something was wrong. That's crazy. I still can't believe that.
I know. So now I'm still paranoid. Like, all the time, I'm like, Zach, will you cook me a steak? I don't think I've had enough iron. And he's like, this is real convenient for you, isn't it? I was like, it is.
It's working, right?
I need it. Medically, I need it. Cook it for me.
Yes. Yeah. Screenings are so important. So important. I'm trying to think of another screening. Even like skin screenings. Like, you know how many people are saved from skin cancer because they went and just got a overall skin check? Like, especially if you're fair skin. If you're redheaded, fair skin, you burn easily, you probably need someone to look at your back because you can't see back there. So things like that, just, I don't know, especially if you have insurance, use it. Get those screenings done. They're usually covered if it's a screening.
I'm starting to kind of, I don't want to say buy into conspiracy. Mm-hmm. I'm like a middle of the road person, right? Like I'm like least invasive measure first, you know, like people were living well, like what are biblical ages? Like was Enoch like 800 or something?
Yeah, it was,
you know, like I forget the exact number. Like people were living for a long time prior to pharmaceutical medicines. Mm-hmm. So I think that there is truth to holistic approaches.
Right.
And I do think that there is time for pharmaceuticals, you know, but as far as like toxins and stuff like that, like, what do you think about sunscreens? Have you seen any of those things? Like I've been seeing mm-hmm. like the sunscreen and the chemicals used in that are more harmful for your skin and your respiratory mm-hmm. system than the actual sun exposure itself.
Yeah. There's better options as far as sunscreen, which ones not to take. Yeah. I know what you're talking about.
Or I think too, like gradual sun exposure, mm-hmm. right? So if you're coming straight from winter months where you've been covered up for 3 months or longer,
yeah,
you can't go lay on the beach for hours the next day. Mm-mm. You know, like just gradual sun exposure, let your body build up that, I don't want to call it a melanin shield and like sound mm-hmm. ignorant, but in my mind it's like
prep your body for
the
sun. Like introduce it.
Right.
Yeah, I agree. That could be a whole nother episode by itself, is the amount of things out there that we could talk about that interfere with our hormones that are actually more harmful for us, and then just things in your everyday household cleaning products.
Yes.
Your toothpaste, your mouthwash, like your hair, your shampoo. Like we're gonna have to do it.
Yeah, we'll make an episode on that one. Let's save insurance for another episode.
Yeah,
because that is a big pet peeve of mine. Yeah, it's frustrating mm-hmm. as a consumer and as a provider.
Yes.
Insurance across the board. I'm not naming out any specific entities, but mm-hmm. across the board insurance.
They're not for us. They're not for the patient.
We can even take it from medical and go to even car insurance too. Just it feels like all insurance across the board today mm-hmm. is. I'm going to say it feels fraudulent.
Yeah, absolutely.
It feels fraudulent to me.
Absolutely.
Well, I think that'll do it for Pet Peeves.
Yeah, episode 2 is done.
Yes.
And if you haven't watched episode 1, it kind of gives us a basis, but you can skip over it. This is episode 2, and then next is episode 3. So stay tuned.